This is, part of my lab is focused on Venetoclax resistance for many years. I was involved in the clinic when we did the original phase 1 studies, and patients with CLL actually died from tumor lysis syndrome, and we almost lost this drug. It turned out to really be a paradigm shift in how we take care of myeloid disease, and is now the basis for all we do in drug development. How do you improve on Venetoclax plus DNMTI or Venetoclax plus low-dose Ara-C, or what happens when patients relapse after Venetoclax? And really a focus right now is how do you manage Venetoclax toxicity, and how do you fine-tune the treatment for different patients? And this is a big deal in the community where patients are being seen by physicians who are less familiar with managing these toxicities than some of us who've managed dozens of patients on clinical trials. From our end, we're very involved in first looking clinically at the features that patients who were resistant to the Venetoclax-based regimens. We also were involved with chemists who had built small molecule inhibitors for MCL1 and did some survey of AML patient samples and MDS patient samples, and we learned that AML samples are, unlike CLL samples, not homogeneous with respect to their dependence on BCL2. So they're fairly heterogeneous intra-sample and between samples. And we said, well, wait a minute, BCL2 inhibitor is not going to work as well in patients who are not BCL2 dependent. And it turns out, through our work and our collaboration with others, we found that specific types of disease, monocytic leukemias, myelomonocytic leukemias, tend to be less BCL2 dependent and tend to have a less chance of responding, or if they respond in the clinic, a greater chance of a quick relapse. This work has been further elaborated upon, where we know that it's phenotypically these myelomonocytic disease, but it's often driven by certain mutations, which causes changes in mitochondrial metabolism. MCL1 inhibitors were really the most exciting thing in development there for a while, but there's some on-target toxicity in the cardiac tissue, and this is going to be a challenge in inhibiting MCL1. There's different approaches in how to do this. So there's drugs like dinaciclib, which indirectly diminish MCL1. We've done a lot of work to try to find different agents that diminish the MCL1-driven resistance to Venetoclax, like selective inhibitors of nuclear export. And then there's new drug development efforts to try to tie anti-MCL1 payload to a monoclonal antibody or so forth. So we'll see what happens, but I think in the future, targeting BCL2 dependence is not going to be enough. We're going to have to think about blocking other anti-apoptotic molecules in the mitochondria.